Good afternoon, and thank you for joining us today. My name is Anton Gunn, and I'm an advisor to the intersection and the moderator for today's panel. Now, I've worked as a community organizer, an advocate, a state policymaker, and a chief diversity officer for a health system. So I know the challenges of working to advance anti-racist health systems. I also know the power of data and how it can be used to illustrate inequities in health. It helps to identify areas of improvement and can be used to improve hiring practices, and often it can be a catalyst for change. See, data, when used correctly, can transform entire systems for the better. So whether you work in healthcare or whether you're a community leader, I know that many of you are at different stages of incorporating data to advance your health equity efforts, and that's okay. Some people are just looking for advice on how to collect and access the data that they need. Others are wondering where and when and how to start analyzing once you have a mountain of data in front of you. And others are struggling to get colleagues at various levels of an organization on board to see the data, believe the data, and act on it. And then there are others who may have a solid foundation and are looking to expand and advance what's already done. No matter where you are, you got to learn about how data benefits you. And at the intersection where community advocacy and healthcare leaders join forces to share resources, experiences, inspiration about this challenging but essential work, that's where we are today. This is a community that encourages collaboration with others. It's a place where we can candidly discuss what is working and what's not working and get strategic about your efforts. So I want to make sure that everybody checks us out, check our website out at meetattheintersection.org to access resources on health equity topics. You can find recordings of previous conversations and resources from a whole group of RWJF grantees and short videos with health equity leaders. There's also a podcast that we have called The Intersection, where racism and healthcare meet, and it's available on all streaming platforms. Again, it's called The Intersection, where racism and healthcare meet. And if you've not signed up for The Intersection's LinkedIn page, please do it today. It's on LinkedIn. It's called The Intersection, and you can connect with others, stay up to date about future events and resources, because we know that we all need a community of us doing this work, and we need it more than most people because this work is tough. It's hard. And so we're trying to help you to find your tribe and learn from each other. The goal, again, is for all of us to learn. So that's why I'm really excited about today's discussion. But before we dive in, I got a couple housekeeping items that I want to orient everybody to. So if you have questions about anything that we say in this discussion today, I want you to type those questions into the chat. See, we're going to record a podcast after today's panel. And that panel, those questions that you put into the chat will be the bulk of the podcast. I'll be real clear about it. The whole podcast will be responding to the questions that get put into the chat. So if you don't put any questions into the chat, then we're going to have a great conversation, but it won't hit the right notes of the things that you need to know and you want to know about how to use data in ways to help you to advance anti-racism and improve the healthcare system. The second thing I want to give you from a housekeeping standpoint is if you will stay with us for the breakouts after the panel. We're going to have some breakouts after the panel. This is an opportunity to continue the discussion. So I hope that all of you will stay for the breakouts after the panel. This is where you'll get a chance to meet other people who are doing this work as well. Now, if you plan to stay for the breakouts, I want you to pay attention to this third thing. And you need to be in a room. I want to make sure you get into the room quickly as possible. And if you're on this intersection event today and you need an ASL interpreter, please make sure that you send a private chat to event support so we can get you an ASL interpreter and make sure that you're in the room where you have the support that you need. But again, everybody, type your questions into the chat, number one. Number two, stay for the breakouts. We want you to stay for the breakouts. And number three, if you need an ASL interpreter, please send a private message, a private chat message to event support, and we'll get you started. All right, everybody, let's get down like the Boogie Down Bronx would when they started this thing called hip hop. So today, I am joined by an incredible panel of experts who are dedicated to advancing anti-racist health systems through the use of data strategies. First, I have Kimberly Alexander. See, Kimberly is a passionate advocate for public health and equity with more than 2 decades of experience in health policy, multi-sector partnerships, and community engagement. Kimberly serves as the co-chair of the Greensboro Health Disparities Collaborative. It's a community-led organization, and she is an active member of a Partnership for Healthier Durham Task Force for Racial Equity. So please welcome Kimberly here. Our second panelist is Dr. Sam Seickert. He is a professor of medicine and co-chair of the UNC Lineberger Cancer Center Equity Council. At the UNC Chapel Hill, this is all at UNC Chapel Hill. He started his career as a solo practitioner, learning firsthand how real-world issues led to variations in care. And as a founding member of the Greensboro Health Disparities Collaborative, Dr. Seickert has led research projects aimed at reducing health disparities, including efforts to enhance cancer care outcomes for people. And our third panelist is Dr. Dawn Godbolt. She is the Director of Health Equity at Maven Clinic, the world's largest virtual clinic for women and family health. Dr. Godbolt leads the health equity portfolio, shaping care delivery models that position digital health as a tool to address disparities in reproductive health. And she was heavily involved in developing critical federal health legislation, including the Black Maternal Health Omnibus Act of 2021, among others. So I want you to say thank you, and I want to thank all of the panel for joining us today. I'm really looking forward to this conversation. So let's jump and get started. I want to start with you, Dr. Godbolt. When organizations begin to capture and analyze data to improve health outcomes, clinicians and staff can feel some uneasiness about the data. So what are some strategies you've used to help making digging into data feel supportive and collaborative?
Sure. So to take a really quick step back, good afternoon, everyone. Thank you so much for joining us today. I am the inaugural Director of Health Equity at Maven Clinic. For those of you who do not know, Maven Clinic is an add-on benefit to your employer-sponsored health insurance or your state health insurance plan. We work with over 500 employers, all the major health plans, and we cover almost 20 million lives across the country and around the world. When I joined Maven, it was an interesting time in our society. This was at the very beginning of 2022. We were in a post-COVID, post-George Floyd world. Healthcare had shifted to social and structural determinants of health and disparities, but a lot of what we saw in our everyday society also bled into how we deliver healthcare. And so in that vacuum, there was really a space for directors of health equity to emerge, develop a strategy, execute, and implement. The only problem is that not a lot of people knew what a director of health equity did. And I was actually coming from the nonprofit and reproductive justice spaces into a health tech startup. So a lot of what I had to do is take the ideas that I had learned in nonprofit policy work, advocacy, and then look for the opportunities to implement them and build them out at Maven. So one of the things that really helped my success at Maven was from the very start, I had buy-in from our executive leadership. My boss is our chief medical officer. He had started at Maven about 6 months prior to me, where he was building and designing his clinical organization. And as a part of that, a director of health equity was, a critical role that he saw need for. And that's when he brought me on. I met with about 10 or 15 directors of health equity at other companies, other organizations to figure out what do we all do. And one of the key lessons was actually in building relationships. And so I had the executive buy-in, I had the transparency, I had the autonomy. I had maybe a gentle shove telling others that if Dawn comes to you and she's asking questions, she's here to help you. And so really setting me up as a problem solver, a fixer, someone who's solutioning, really helped people understand that health equity is a team sport. Everyone is responsible. A lot of times we point at different actors in the healthcare system and we can say, oh, you didn't do this right, or you didn't do that. When we use a health equity framework, or I use my framework, it's saying, okay, listen, we're going to look at the past to make sure we don't make those mistakes again. But right now, moving forward, we are starting over, and everyone has an opportunity to take a part of that. And people like to feel as if they are a part of the solution rather than the problem. One thing that I will point to, and I know we'll get into it a little bit more, is at the end of 2023, we developed a culturally and linguistically appropriate services program per Health and Human Services. And the nature of the program is one in which cross-collaborative partners have to work together. And so at a company like Maven, that's bringing all of your clinical leadership to the table to look for those opportunities. It's really helping people understand that now we're fixing things. And that really resonates with people. I will
Very
pause there and add
good.
more shortly.
Great. Yeah, great. We'll come back. There's a lot more to talk about. So I'm going to bring Kimberly into this because it's really cool to see a community-led organization that's so focused on data. So I want to ask you about the collaborative's effort to improve cancer treatment. How did that initiative get started?
So thank you, Anton. And I think Don had a great point about health equity being a team sport. So the Greensboro Health Disparities Collaborative is a collaborative of academics, community members, and healthcare providers. And those folks aren't usually all in the same room, but I think history is really important and matters. And so I want to name Nettie Code, who was our founder, a community organizer in the community of Greensboro, a Black woman who represented her community in the neighborhood association. She was active and making partners across Greensboro. And so when she had a particular unsuccessful and harmful event in our local health system, she said that she really wanted to figure out how to fix this. And so was communicating with neighbors and folks in her community and reached out and said, we really need some academic folks who can help us understand what we need to do. And so the Greensboro Health Disparities Collaborative is community-driven and community-led. So it starts from community and going to the academy to say, we really need some help figuring out how to be able to do this work. And so we're going to talk about data today. I'd love to be able to say that an important way that we got started was hearing from community members, and so gathering data through focus groups. So data isn't just something that's owned by the healthcare system over here. We want to say that data can be owned by all of us. And so the collaborative started from community members going to healthcare partners and academics, and you'll hear more from Dr. Seichert later on about his role in that. But we really started in that way, hearing from community. What are the needs that are bubbling to the surface? And that's how we got to breast cancer disparities that were happening in the Cohen Health Foundation. And so from there, we've been about 20 years in partnership. So I do want to say that this kind of work takes a long time. So I want to set expectations that we're not going to change everything overnight or in 2 weeks or in one particular grant cycle, but thinking about how things can change over time. And so that focus on breast cancer, we said we wanted to make sure that we could include men too. And so breast cancer and lung cancer were the focus of our ACURE study. And so I think they're going to drop the link to describe our case study from the Greensboro Health Disparities Collaborative so you could see a little bit more about the background, but understand how everybody on the team has a part in that beginning for health equity.
Wow. So first of all, I heard a couple things I want to pull out. Number one, this takes time. Number two, community can lead it. It is a team effort. to bring all of this together. And you mentioned Sam. And so Sam, I want to pivot to you and ask you a little bit more about the Cancer Treatment Initiative, because I do know that, clinicians have to be involved in this, and you have to have, healthcare-based leadership also involved. So how did the physicians, clinicians, let me just say clinicians, broadly clinicians, and the healthcare leadership respond to the collaborative ideas to focus on, lung cancer and breast cancer as the treatment needs? What were their responses? Share a little bit.
All right. Well, back in the day, data weren't as readily available, okay, because records were paper records. And so to them, everything was great. And so the idea of, oh yeah, you can come take a look. We don't think there's a problem. And that reflects back to Kimberly, because the community stories saying, it isn't great, was a real stimulus about pushing through the door. So initially, when the collaborative got together, the main data source was the cancer registry. And to get data from the cancer registry and then to put it kind of in a spreadsheet format where you could look at it by race and other things, it wasn't something that they did regularly at the time at all. And so we discovered in our initial study together something called C-CARES. Oh yes, there's a gap in completing breast cancer care. And oh, by the way, we see that patients started chemotherapy, but we don't see where patients finished chemotherapy. So there were a bunch of omissions in the cancer registry. But fortunately, as time went on with the High-Tech Act in the Obama administration, everybody digitized. So now all of a sudden, digital data are everywhere. And so that's a long answer to the question. What did physicians say? At the beginning, they said, have at it. But then when we saw differences and people started using terms like institutional racism, they got really mad, because most physicians still feel like they're inherently idealists. And so you throw around racism, they're there, oh, you're calling me a racist? No, 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 no. And so we had to take the approach of, this isn't your fault. This is something baked into the institution and the way they do things. And we'll get to implicit bias a little bit later. But anyway, there was real pushback when we used terms like structural racism, institutional racism. So when we backed off to system level bias, we had partners again.
Yeah, in my experience, I remember a colleague saying to me that when someone presents some data to you that is not favorable or it doesn't look good, the first approach is always to argue with the data and whether the data is actually right. And then once you can't argue with the data, you argue with the persons who are presenting the data. So my question really goes to Kimberly and also to Sam around when the data was pretty clear that there was something there. Talk about how you overcame that pushback. And I'll kind of start with you. Did people receive it because it came from the community, Kimberly, or was there resistance to it?
I think it's really important to note that in the Accure study, we started with national statistics to
Okay.
be, this is a problem everywhere, that these are disparities that exist in lots of places. And then, as Sam was saying, physicians often say, well, that's not mine, or my patients are sicker than everybody else's. But being able to use national level data and then our local data to say, this is not just a problem over there, but it's also a problem here. And being able to see that data and see what was happening in those clinics and being able to break it out in ways that maybe hadn't been the focus before. But Sam was actually a part of that. So I'd love to hear him share a little bit about that.
Yeah, so yeah, that's all true. And so even before dealing with the cure and cancer disparities, I've been doing quality improvement projects, and whether it's hypertension, diabetes, cardiovascular events, it doesn't matter. The response the first time someone, whether it's a physician or administrator, sees data is, oh, that's not true, or my patients are sicker. And then you get the data another way and even do things like hand chart reviews, and they see the data again and they say, oh, okay. But at that point, when they see it twice, they usually say, this is a problem, let's fix it. And another thing we dealt with, being in Greensboro, North Carolina, we heard, oh, it's a Southern thing.
Hmm.
And so when we actually did the intervention study, we included a northern site, which, by the way, had some of the worst disparities.
Hmm.
And so anyway, in the work, we dispelled the "it's a Southern thing." And with the intervention as we went forward, we also showed that the solution isn't just a Southern thing.
Very good. That's very helpful to understand,
Okay.
Going national and then bringing it down to local, because it's harder to argue with when you can see it across zip codes and time zones. That's really great. So I want to bring Dawn back into this. Dawn, you mentioned in your opening remarks, you were the first health equity director at the Maven Clinic. Okay. And I want to ask about this because I know there are people who get the words health equity thrown into their title, or maybe they become the health equity director at an institution that didn't have one before, and you're the very first. So I want to talk about what makes your role successful. How do you collaborate with others that work in quality and safety or clinical care and elsewhere in order to help the people out here who may now have just added this as a new title, or the first ever to do it at their institution and are trying to figure out the pathway to find success? Can you talk a little bit about what made your role successful?
Sure. So again, with not a lot of directors of health equity existing, but people being familiar with the term director of diversity, equity, and inclusion, there was a lot of work to do around definition and even role definition. And so I probably spent the first 6 months explaining to people that I was not the DEI director. That is a different strategy. That's a different focus. What I was looking at specifically were our health outcomes. I was looking at gaps. I am housed within the clinical organization, and what I am focused on is understanding who our members are and where there are opportunities for improvement in both utilization of the app. And so that looks like birth planning. It looks like meeting with specialists or following your care plan. And then I was also interested in our actual clinical outcomes, NICU avoidance, cesarean rates, lactation, and return to work. Part of, I think, my success was in the development of the clinical organization, building in functions that collaboratively operate together.
Hmm.
And so it could be our value-based care team that's developing the projections for how we will deliver better care. We have performance guarantees. So with our clients, the employers, and the health insurance companies, they are asking to see this information. How do you disaggregate this? The national data is telling us that Black women are more likely to experience death from pregnancy-related complications. So what are we doing specifically for our Black members? In order to do that, one, I'll go back to the data collection and making sure that's robust. But the nature of a digital health team, we've got our clinical org, we've got clinical quality, clinical research, value-based care. I'm forgetting a handful of other people. We have all of these people that work together. But one of the real challenges in a digital platform is making sure that the engineers and the product designers are also coming along with us.
Wow.
And so if they say something to me, I'm saying, hey, I want to add all of these questions to the onboarding process. And a question may be asked, well, do we really need to collect gender identity and sexual orientation?
Mm.
And so then explaining to an engineer who's never taken a public health course and is not aware of a lot of health disparities, getting them to understand, right? First, hey, gender identity and sexual orientation are two different things. And this is why we have to collect it different, or we have to collect both metrics, and why we would disaggregate differently. So very cross-functional, very collaborative process. But the fun part of being a director of health equity, right? First, we have 400 years where nothing has worked, 400 years of bad behavior, ideas or suggestions that don't go anywhere. And so really understanding, one, we don't have a lot of time for this, but two, this is where we develop ideas. This is where innovation comes in. HHS, they recommend that any member or patient-facing organization create a class program. Well, how do you execute that on a digital platform? How do you create that? How do you track the sources of data? We track 6 different sources of data on a quarterly basis. And it's even things like our staff training, who is completing health equity courses. It's all of these things. It's understanding our demographic and patient match. Do we have a critical mass of certain demographics to be able to do what we call care matching, which is where we offer an opportunity to members to meet with someone who has a shared cultural background. So it's a very cross-functional role within the organization, and there has been a lot of room for creativity. I went to our chief medical officer and I said, hey, we need a community advisory board. That if we're going to do health equity, it's a bi-directional process, and we need to be able to allow the community to tell us, what do they see, what do they need, what do they recommend? A lot of
Very
that.
good. Very good. So that was a great framework, and you threw a lot of amazing stuff out there. But what I like for us to do is, let's see how we can help the person I want to get real practical. Like, if you're just beginning to dive into data to support health equity wherever you are, from the three of you, from your different perspectives, what types of data would you prioritize collecting? I heard you lay out a few things, Dawn. Kimberly, I know you said a few other things, Sam as well. So like, if I'm just getting started today and I don't know nothing from nothing, but I know that there's a problem in my gut, I feel there's a problem in the gut, and I want to start collecting data, where would you prioritize people to get started? And I'll start with Sam first.
Well, before I get to that, I want to agree and yet disagree with Dawn.
Okay.
On the agreement side, one thing that I've seen over and over again is, as new programs form, instead of the typical place, instead of planning with equity and optimal care in mind, they just start it and wait till the disparities happen. And then they're constantly trying to catch up. So the sort of universality of digital apps can help with that. But on the other hand, many people don't use digital well, don't use apps well. And many a study has shown that poor and disadvantaged communities are communities that tend to reject digital stuff and reject apps. So sometimes you can get disparities all over again just by who's using the new stuff. So apps are great, but they don't by themselves solve the problem.
Very good. I remember I was having a community-based conversation, and we were trying to collect data around diabetes. And one of the clinicians literally said, well, everybody has a smartphone. And I reminded people that just because people have a smartphone doesn't mean they use it in a smart way. And it's a bad assumption to assume that everybody actually has a smartphone. So a great point. Again, tools and things we got to use. Okay, so let's go back to my original question.
Sure.
Practical.
Do you want to respond to that, or we'll come back to it?
You can. If you want to respond to it, feel free.
So we have this come up in different calls with our clients, and this is where we have to say, one, we work with your healthcare system, but two, there is a targeted audience that is using it. So like any other system, right, you typically have Maven as an add-on benefit to your employer-sponsored insurance. So we can take a step back right there and say who has employer-sponsored insurance. So right, that's a case. We also work with a number of Medicaid plans. And so we do a lot of testing with our Medicaid population to understand their access to care and other ways to reach them. And we actually have very good results looking just at a lower income population and a rural population, how digital health can really bridge a lot of those gaps. And so if we're talking in this case about someone who's seeking reproductive health care, if you're in a rural area, you may wait months or you may travel a very long distance to see a reproductive health endocrinologist. As a virtual platform, you have access to over 1,500 providers, 30 different specialties. And so lots of challenges, entire healthcare system, but there are many ways that digital health can actually bridge gaps in access to care.
Very good. Very good points to frame up. Okay, so go back to my question. I'm ready for it now. And I'm going to start with you, Kimberly, so we can keep the positions in the leaders in a good frame. So what would you say people to start from a community-based standpoint? If I've never collected data, what would I prioritize first? What should be first?
So I think it's important to think about who are the people that are interested in collecting the data. And
Okay.
so understanding that the partners that you have at the table, like in the collaborative, we have community members, academics, and medical partners, thinking about making sure that we're all on the same page. And so I'd say before we start collecting data, to make sure that we're all using the same language. So the
Right.
example with the Health Disparities Collaborative is that we have a training that all of our members, academic folks, folks who are seeing patients, and community members go through the Racial Equity Institute, groundwater, and phase 1 training. That's a 2-day training based on the People's Institute for Survival and Beyond, based in New Orleans, so that we understand and are using the same definitions and common definitions of racism, understanding power and how it interacts, so that when we come to the table, we are using the same common definitions, because folks that are in community that are going to work every day may not have the same level of discussion with a physician who is seeing patients every day. So we want to make sure at our table we're using common definitions and have a common framework. And so I think that was dropped into the chat as well, a little bit about the Racial Equity Institute and that part, so that when we're talking about what we want to collect, we're able to do that using a common language. And so I would suggest that focus groups might be a great place to start. I know there was a question in the chat about when you have a very small number of people, because the Health Disparities Collaborative, we started with about 30 members. That's not really enough to do something statistically significant, but we had the opportunity to be able to hear from community members, to hear from the providers, what are things that folks are seeing, and had those conversations split into groups that were race concordant. So Black folks were having conversations with Black folks about their experience. What are some things, what are some experiences that we've had in the healthcare system that we want to address? And so those focus groups were a great place to be able to start to figure out where we wanted to look before we decide to just go see what's available. That sort of thing.
Very good. So Dawn, what would you recommend someone that gets started if they're starting to collect data? What would be important to start with?
So, depending on where we're starting, we want to at least get race, ethnicity, preferred language, gender identity, and sexual orientation. I would argue to throw a zip code in there as well. I think a lot of the people on the call may be collecting those baseline metrics, and that's where I would say, let's go a little bit further and start collecting social determinants of health data as well. At Maven, about a year or so ago, we created a digital health tool that can be used to screen for social needs. Part of the problem with most social needs screeners is that they're too long. They're too long, they're burdensome, and providers give them to people who they think may have a social need. And so creating a short form screener, 3 questions, we're able to get at, do you have safe housing, access to food? Do you have a village? Are you lonely? Really understanding more of the context of who your members or who your patients are to be able to provide. I mean, for us, right, you can't fix what you can't measure.
Yes.
And then once we measure it and we see the gap, that's where the opportunity for quality improvement comes in. So it's definitely, yes, Lily, the screener is publicly available. I will drop a chat. We did that because we really wanted people to have access and use a tool that could collect the data in a robust way.
Very good. So this is great. Great. And Sam, we're going to get to you next. But before I go to Sam's answer, I'm going to pause this conversation right here and we're going to share a poll. So if you plan to stay for the breakout groups, which will end by 2:30 Eastern time, we hope you all will stay. We want to put this poll up now and give everybody a chance to answer the poll to let us know whether you plan to stay for the breakouts. You get a single choice answer. We'll take a second to answer this breakout poll. We want to know whether you're staying, and then we'll get to Sam's answer around where people should start. So please feel free to answer as quickly as you can so we can get back to the meat and the potatoes of this great conversation. All right, great. Very, very helpful. So Sam, tell me if we're just getting started on trying to collect data. We heard some great framework around SOGI data, sexual orientation, gender identity, race, ethnicity, even zip code, social determinants. What would you say is important for someone if they don't have a lot of resources to get started collecting data? Where would you advise to start?
Okay, so I'm going to take it from the viewpoint of I don't have access to the health system. I'm out there in the community and I want to know if there are disparities in my community. And almost every state has a website that statewide will give you data on things like cancer incidence and cancer mortality. And that publicly available website, and actually you can get it through the CDC as well and pick the state, though it's a lot of clicks on the CDC site. But anyway, this uses cancer registry data, which is inherently a year old. So it's not real-time data, but it's as close as you can get on a public site. And you can find disparities by both race and ethnicity on a statewide basis. If you go to a county level, you can find what the mortality and incidence is and how it compares to the country. But most states won't give you county level data because there's usually one health system in that county. And so they're not going to lay the finger on that health system. Now, to be able to get actual local cancer registry data or health system data, the way the world is right now, they're not transparent to the public. So you have to be able to get a partner within that system and have the partner advocate for you to get that data. And thankfully, as part of the ACCURE study, we were able to get actual electronic health record data up to the minute in real time in the health systems we were working in, which really, by getting real-time transparency, that was one of the keys to be able to alter the outcomes of cancer patients.
Very good, man. That's powerful stuff. I'm going to share a little bit of transparent experience. I worked at a large health system who collected a lot of this data that we all laid out, race, ethnicity, gender, zip code data. Hospitals and health systems collect all kinds of data on their patients, even payer status, who's Medicaid versus private insurance. There's all kinds of data. But sometimes organizations won't do any kind of analysis or any examination on this data by race or ethnicity. They just won't look at it that way. So if you are trying to help a person in an organization, Sam, you mentioned finding a partner inside an organization, where would you all encourage a partner to start? Consider, examining data that it's already been collected? Is there any aspect of data that would be important to start? And Kimberly, I'll start with you as a community representative. Where would you, if a health system partner says, "Hey, we got plenty of data, but we are trying to, start to analyze about race and ethnicity," where could they begin? Where could I begin? What would you say?
That's a good question, Anton. I'm thinking about the relationship because we had long-standing relationships and had built trust with health system partners. If someone was to say they have data, we want to analyze it by race, where would we start? That's a good question. I think it's important to understand what it is they want to do with that information and figure out the audience they're going to be sharing it with. So if they're looking to be able to share the information with community members, they could focus in a particular area to be able to share some of that local data that may not be available by to be able to share some of the health system data that might not be available to those community members. So if there's a particular health issues, like we focused on cancer, being able to share some of those and asking to break it out. Is it available? Have you even recorded the information by race and ethnicity, and being able to break it out that way? But I
Very
think
good. Dawn, I see you kind of chomping at the bit. I know you got something for me. What you got?
To add on to Kimberly, if you are collecting data but you don't know what to do with it, I highly recommend that you check out HHS's Culturally and Linguistically Appropriate Services Program. As an app, we were drowning in data. We knew everything about our members, but now what do we do? And the class program lays out how often you should review data, what type of data you should review, what your aims should be, and it even tells you how to set goals. And so you're going to set goals for improvement. You're going to track these goals quarterly. You're going to initiate quality improvement processes based on all of the work you're doing with the data collection, review, and analysis. I cannot recommend following HHS guidance and class programs enough.
Very good. Sam, anything you want to add there?
Yeah, the number one killers in America, the number one causes of premature death of adults are cancer and cardiovascular disease. And we found in our work, in our intervention work, that you can make a mammoth difference by intervening and making care better in those areas, even with data that shows improved mortality. So that if you want to make a big difference, cardiovascular and cancer is a great place to start. And when you start getting into all sorts of things like multivariate analysis, I mean, how many hundreds and thousands of times has it been proven that people of color are getting the short end of the stick in healthcare, right? The short end of the stick in outcomes. So we can do control for things like comorbidity insurance and all that to make our argument. But when you see big gaps, there's a big gap.
Mm-hmm. Mm-hmm. That's so real. I mean, like, I'll never forget, I was talking to a healthcare system who, even when they didn't look at data by race or gender, they just looked at it by zip code. And they saw some disparities in wait times in the emergency room. Like, if you came into an emergency room and you came from this zip code, you waited for 197 minutes, versus if you came from this zip code, you only waited for 97 minutes. And so that lets you know there's some disparities. And of course, you can overlay the socioeconomic status, you can overlay the race of those zip codes, and then also look at the gender of those patients. So there's a lot of stuff you can see there. So let me ask this question. And I know everybody wanted to know when the breakouts will start. We're going to start the breakouts at the top of the hour, right at 2:00. But we got a little bit more stuff I want to unpack here in this conversation. We're going to close talking about wins. So I want you all to start thinking about what are some successes and wins that you've had by collecting, analyzing, and reporting out data to to close the gap on disparities. But before we get there, we know that I asked you about where does somebody get started. These are some basic data points that everybody should be capturing: publicly available data, data that you compare nationally to locally. All of those things are, a way to get started. But my next question would be, is if you have gotten started on this journey and you see that this data is not really telling us or showing us where the problem is, and you can't really see the data that you need. So how do you effectively make the case for expanding data efforts, whether that means more staff, more funding, more collaboration across the organization internally, or even with external partners? How do you make that case? What would you say to someone? And I'll start with you, Dawn, because I know you come before in your current role, you were in a different sector. So how would you make the case for an organization to expand its data collection efforts to really get to the problems that you know and believe are there, but you don't have any data to support it?
Okay, I feel like this is a big one. I will refer back to the idea that we can't measure or we can't fix what we can't measure.
Mhm.
I'm also really interested in a lot of healthcare systems. In Maven's case, we are accountable to the employer and to the healthcare plan. And so I would think about the accountability mechanisms, the structures behind why you're doing this. And so in a case like Maven, our incentives are driven by our clients. We work for health insurance plans. And so as health equity or standards or data collection becomes more robust, they look to us and they say, are you able to meet those standards? Are you able to meet the guidelines? And then internally, our systems fall in line with our partners, all of our collaborative partners. Anton, I don't know if that was directly answering your question, but
Yeah, it's good. It's good. And I'm going to have Sam go next, because I want you to tell us how the Acura intervention, initially created to improve cancer care, is evolving to advance health equity efforts for other patients. And is that an expansion of data collection? So I'll let you go, Sam.
Yeah, well, I have to start with the experience back in the collaborative. The collaborative said that, first of all, this isn't one bad apple in the barrel, right? It's not one racist here and there. This is a system problem, so the intervention has to be a system intervention. Second of all, like Dawn said, if you can't measure it, you can't fix it. And if you can't see it in real time, then you can't intervene in real time. And so transparency in real time, accountability, somebody has to be responsible for what you're seeing. And then finally, you have to have communication. Our communication with patients is often horrendous. And so you have to engage and re-engage until the patient understands. So putting those things in the intervention, when we had real-time transparency, if we found a patient falling out of care acutely, I mean, it didn't matter what the reason was. We could engage the patient and the healthcare providers and find out what the reason was and drill down on that reason, because in real time, we knew there was a failure, a disconnect. But with those three elements, so for transparency, we had a real-time digital registry where we had warnings for patients who didn't meet their milestones or missed appointments. The second thing, by accountability, we went to the healthcare providers, the healthcare teams, and said, here's how your patients are doing according to race. So if there's a gap between Black and white, what do you think the gap is? How are you going to iterate with us? And the third thing is we had a navigator who was specially trained by REI and in some other ways, understanding the specific barriers of people with color, so they could engage and re-engage the patients. So with that intervention, we went from a 10% gap of 80-ish percent-ish completion of care for white cancer patients who were curable. So the 20% who were curable, not getting care, that's not so good either. 70-ish percent for Black patients. Well, why should I not get care for something that's going to kill me, right? Why should I not finish my care? That doesn't make any sense.
Mm-hmm.
And so with the intervention, care on a system level basis was almost perfect for everyone. The numbers went into in a lung cancer 5-center alone study we did, it got into the 96 percentages for everybody. And so system-based, taking what the community says and technically putting it into the health system works. And now we've applied it to cardiovascular stuff and it's working. And we're now studying the use of this system in maternal and infant outcomes.
Wow, fantastic. So, Kimberly, I want to come to you with talking about wins. Like, my context is that, you have a community led organization that's built a lot of trust and a lot of partnership. And so, and this has happened over time. So I want to talk about, to highlight, what have been some wins that you have been able to yield out of this partnership, and where you're going from a community-based standpoint. And I want to hear wins from everybody if there are wins.
So I think the first one is what Sam just said, taking cancer treatment adherence. So when we talk about cancer treatment, we're talking about saving lives. If you don't get the treatment that you need, we were losing lives, but not just improving those cancer treatment adherence rates disproportionately. Everybody did better, and everybody was better about attending their care. And so we're saving lives. So I like to say, oftentimes when we talk about health disparities, folks think about, oh, well, we want to make sure that Black folks get to where white folks are. White folks aren't doing so great either. We want everybody to be doing better. And that's the way that I think that's the biggest win. But also the relationships over time, because we've been able, as Sam was saying, to apply what we've learned, not just to cancer and to these two institutions, but now we're doing that. Sam has led studies in cardiovascular disease, and we're currently in a study that is statewide in North Carolina, looking at OBGYN practices and how to apply those same things. We're in the ACURE study. We just had 2 cancer centers. Now we've got 40 practices in North Carolina that are using these same tools that Sam talked about, the real-time registry, the health equity training for the professionals to understand the national disparities and what's going on in their clinics. And those navigators, or the folks, the doulas, the community folks that are right there in the practices, making sure that when people are missing appointments, when things are happening, that we're seeing what's happening right there and then making those changes right away. And so being able to learn those lessons and apply them across, I think those are some of the greatest wins.
Fantastic.
And just 2 really important things. One thing we haven't talked about is the effect of experienced racism on stress and epigenetics. And part of this study with maternal and infant health is with the doulas helping the patients along, we're actually measuring experienced racism and then correlating that with outcomes and then the factors attenuating. So that's one important point. And the second thing, for everybody on this call, I hope you listen to this, because in this world where we're getting this pushback that equity is wokeism and we're not doing that and all that garbage. Am I allowed to say garbage on this, Anton?
You can say garbage. I'm good with garbage.
All right. And this is not a zero-sum game. Those people who say we're going to, if we put all these resources into different communities, then people who are getting good care now are going to suffer. That is horse manure. And it's not a zero-sum game, and our study results prove it.
Fantastic. Thank you. So, Dawn, how about you? Wins?
Sure. I think one of our biggest wins when I look at our platform is with our doula model of care. We presented some research at ACOG a couple of years ago that looked at utilization across the platform, and we knew that our Black members were significantly more likely to use Maven than our white members. And for our doula program, about 40% of our members met with a doula compared to only 20% of white members. Last year, we published in Obstetrics and Gynecology the results of our study. We looked at about 9,000 members, and we found that doula care improves birth experiences and reduces odds of C-section rates. And so meeting with a doula on our platform at least twice reduced the odds of a C-section by nearly 20%. And for our Black members who attended at least 2 doula appointments, they had nearly a 60% decreased odds of C-section. And for Black women who are routinely pushed to have a C-section, a riskier procedure, a more expensive procedure, a higher rate of mortality than a vaginal, we are talking about a significant improvement in health outcomes and, depending on your motivation, cost savings.
Wow.
And so we're very proud of the impact that we're able to have on C-section rates through our doula model of care.
Wow. That's incredible. So first of all, thank you all for sharing these great nuggets. And I'm going to bring this conversation to a close because we really could talk all day because I got like 100 questions that I want to ask. And I have seen the chat been on fire all day with all kinds of stuff in there. And we're going to get to those questions in the podcast episode, as many of those as we can in the podcast episode. But I want to close us out with a question to each of you. And I want you to answer it directly. I want some free advice. Most communities don't have anything like what you have in Greensboro, and they definitely don't have this robust data platform that Maven has. In times and places where money is scarce and there are few organizations to help, how can a DEI leader get started? What advice would you give someone to get started where they don't have all of the robust tools and resources that you have? What would you tell them to do to get started? And I'll go through each of you, and that will be our closeout advice for everyone at the intersection. So, and I'll start with you, Kimberly.
I think if I was giving someone advice that didn't have the Greensboro Health Disparities Collaborative or the robust platform, I'd say that it's really important to understand where you are and the history of how they got there. So Greensboro is a place that's got all kinds of history, from the first Black physician that sued to be able to see patients in the hospital, to the ANT4 that sat at lunch counters. The history of a place and understanding where that is really important. And so I think I would suggest, from a community perspective, to understand what's going on in the community and to make those relationships before you get started. And there is data there. I know folks will say trust, and we're talking a little more fuzzy, but that there is data there.
I think she froze up on us. Sam, how about you?
Well, my sort of bland answer is that go to either the CDC or your state health department websites and get at least your state data to get started, and go to the community, and whatever it is that you're really interested in affecting, whether it's the opiate crisis, whether it's cancer, whether it's cardiovascular disease, go to people who are patients and ask them, what have your barriers been? How is your relationship? That's the simplest way to get started. But my non-bland answer is, I think people have to organize and put health systems on a transparent field and say, we know there are disparities. We need to see your data publicly because we're getting hurt.
Man, you just laid it out for every community organizer. I would be salivating if I was in the community for that remark. Thank you. So Dawn, please close us out.
I was going to give the bland response. I was going to say, do that environmental scan. From an organizational standpoint, I spent my first 60 days at Maven. I interviewed about a third of the company, and it was everyone from executive leadership down to our junior level staff to really understand where the opportunities are. The other, I will say, is the power of community partners, community-based organizations. We have several of those programs where, again, it's a bi-directional process. For the reproductive health space, I'd like to point to hundreds and hundreds of reproductive justice, Indigenous-led, Black woman-led organizations around the company that have harnessed community power. They've created their recommendations, their developments. They know what needs to be done. They're under-resourced, underfunded, and they're not listened to. So if we're really trying to make an impact here, let's bring those community voices to the table with us.
Fantastic. Well, first, thank you, Kim, Dawn, Sam, for being here and sharing these amazing insights. I want all of you, get ready for the breakouts. Get ready to start now, but I want to let you know we're planning for some upcoming events and we're looking for speakers. So for all of you in here, we're looking for some speakers. So here are the topics that we want to cover going forward. Ensuring language services, increasing diversity of suppliers, measuring and sharing progresses and successes, and how do you engage a board? So if you know someone who would be a good speaker to talk about any of these subjects, please make sure you click the survey link, the chat, and to share your ideas for speakers. We like to crowdsource good speakers for this, and this is how we got the great group of people that we have today. So make sure you click that link. And we'll hope that you stay connected with The Intersection. Please sign up for updates at meetattheintersection.org. Follow our LinkedIn page and subscribe to the podcast on Apple, Spotify, Amazon, or wherever you get your podcasts.